orthodontic movement, distalization, and molar protraction. This is a video to illustrate how can a mini implant be used as an anchorage where it's connected by a means with an orthodontic appliance. Usually it's a night-eye coil spring or an elastic thread. And it gives almost zero anchorage loss. I don't know. Okay, how to select an orthodontic mini implant? Usually we have a self-drilling mini implant and self-tapping mini implant. Self-drilling means there is no pre-drilling is requested, and usually if it's only possible to use a carbide burr just to penetrate the cortical plate. And self-tapping drilling is a must, and usually nowadays we are using self-drilling, but self-tapping is considered as a history. Self-drilling, in the mini implant of self-drilling, it contains like a groove, and this groove is used to allow escape of the bone which is being penetrated during orthodontic mini implant screwing. The regarding diameter of mini implant, usually the smallest one is 1.2 and the largest is 2. The smaller the diameter, the less risk of injuring the roots, but the more risk of easily broken of the mini implant. Regarding the length of a mini implant, it's the smallest is 6 millimeter and the longest is 12 millimeters. The better the anchorage if we increase the orthodontic mini implant, but the risk of injuring anatomical structures. Neck length is usually thick if I'm using the mini implant in a thick gingival tissue, so I have to consider a long neck length, or it's named soft tissue collar, it's the same name. Head type, usually we have 3 types of head. A hole type, and a hole type is usually used with wires like ligature wires and hooks. A button type, which is used mainly with a night-eye coil spring and elastic chain, and a bracket head type, which is used with a sequential. It's used as a unconventional bracket, and it can be used with a sequential wires. Best sites for placement of an orthodontic mini implant. Usually, we have several placement or several sites. Usually, buccally between upper 5 and 6. And palatary or interradicular between 5 and 6 palatary, and mid-palate medial to the 6 at this area, usually. Not at the mid-palatine suture, maybe a little bit beside mid-palatine suture. And interradicular between 6 and 7. And at the third Rugy area, medial to the 4. These are the most popular places or placement sites which are used for an orthodontic mini implant. Other sites may be useful, but it's not guaranteed of a less failure rate. The angulation of a mini implant placement should be perpendicular on the bone or on the site. Size selection, again, we used to like diameter and length and what we have mentioned before, but we have to keep in mind the cortical plate, because the cortical plate thickness is usually ranging 0.5 to 2 millimeters, and this can be checked by a cone beam. If I have a thin cortical plate, so I have to expect choosing a long mini implant for better anchorage. And if I have a thick cortical plate up to 2 millimeters, so it's not ideal to use a long mini implant. We have to keep in mind that males and old age usually have a thick cortical plate, buccally and palatally and lingually. An overview on clinical usage of a mini implant is used mainly for first molar distalization. If we would like to distalize the second molar, we can use a mini implant as an anchorage during our distalization. Just place mini implant between 5 and 6 and connect the mini implant with like a hook to the main arch wire and start activation of a compressed spring to distalize the 7 or the second molar, and again in the 6, mesial to the 6 compressed spring, and don't forget the stopper to retain the distalization which has been done to the second molar, and another stopper to maintain or retain my distalization. Option 2 of distalization is I can bond the mini implant with a wire or a hook directly to the anchor teeth using an orthodontic composite. It's named Helioseat. Helioseat composite can be used in such cases, and the same idea of compressed spring and stopper to retain, and this to anchor the result of distalization. Another usage is maximum anchorage during anterior teeth retraction, either mainly in mass retraction. We can use a mini implant between 5 and 6 and connect with a coil spring to a hook. This hook, according to the type of movement I would like to do, either it's intrusion or retrusion and extrusion, or only retraction of the anterior segment. If I'm going only to retract the anterior segment, so I have to keep in mind to be as close as possible to the center of resistance to avoid extrusion forces or extrusion movement. Molar intrusion we have too many ways to use a mini implant for molar intrusion, but usually if we have missing molar and the opposing is over extruded, so we can consider placement of a mini implant buccally between 5 and 6 and palatally between 6 and 7 interradicular, and connected with a coil spring with a composite occlusally like this. It's a mini implant interradicular and connected with an elastic chain. Okay, or to use a coil spring and bonded with a composite, orthodontic composite. This is only beneficial or can be usable if the opposing is missing, as to avoid fracture of the occlusal composite. While if we have a bilateral extruded molars, like this case, extruded first molar, we have to use a TPA or transpalatal arch and mini implant between 5 and 6 and 6 and 7, and connected with an elastic chain to allow a bilateral intrusion of the over extruded molars. And if we would like to intrude the whole posterior segment 4, 5, 6, and 7 and the same, we have to consider a segmented wire technique, and to consider a TPE as an anchorage with attached to it with a coil spring and attach it to the mini implant. I'm sorry, but this mini implant should be placed, I guess, at the third rouge area, so it's a mistake. It should be placed here to allow an intrusion to the whole posterior segment bilaterally. Regarding molar protraction, we can use a mini implant, again bonded directly to the main arch wire, and start protraction of the second molar or whatever of a molar mesially. Another step or another example of molar protraction is to connect the mini implant directly to the molar, but we have to consider, to avoid tipping of the molar, either to be as close as possible to the center. Of course, it's not possible to protract a molar at the center of resistance. It is unbelievable. So I have to be as close as possible, or to use a thick, stiff main arch wire like 1925 stainless steel to avoid tipping of the molar. Like this. If we can use a mini implant to place between either 4 and 5 or canine and 4, and start connecting the mini implant with the molar to be protracted using elastic chain. And don't forget a stiff main arch wire 1925 to avoid its tipping. Incisor intrusion, we can intrude incisors by placing many implants distally to lateral right and left, and on a wire, and connecting a memory chain or an elastic chain to this wire to start intrusion of the whole incisor segment. Again, in mass retraction, means one-step retraction or a whole retraction of the all anterior teeth from canine to canine using a mini implant attached to a hook, because I would like to only do retraction without extrusion of the anterior segment. Like this video, where we place a mini implant between 6 and 7, or 5 and 6, it depends on the case, of course, and start attaching a memory chain or an elastic chain to canine, which is ligated from which the whole anterior segment should be ligated from canine to canine to allow beneficial or adequate retraction. I don't know why it's doing like that. Sorry? No, it's okay. I'm done. Yeah, thank you. There was a study which takes place in or published in an international journal of oral implantology to compare an in-mass retraction and using a TAD as an anchor unit, or a molar as an anchor unit, and it was found that it was almost zero anchorage loss while using a TAD, but both groups were considered the main average time of retraction. Finally, factors affecting success and failure. We have to consider the mini implant in the main original treatment plan, not to be, if something is going wrong, to use a mini implant. Also, we have to ask the patient to rinse with a Peridex for 1 minute, and we have to insert the mini implant very slowly up to, it's not a problem of how fast you are, but it's a problem of what's your technique and how to be as much as possible less damaged, as to avoid injuring of an anatomical structure of a root. If you're going or you're willing to place a mini implant between teeth like 5 and 6, between buccally, especially buccally between 5 and 6, you have to maybe think about that step or that band. Mainly, it's done on 14 stainless steel or 18 stainless steel to diverge the roots before placement of a mini implant. This is my city. It's Alexandria from Egypt. It's Alexandria Library, and this is Mediterranean Sea. It's like sending a beam of science to all over the world. And this is my second home country. It's Vienna. This is the Opera of Vienna. My supervisor for this lecture is Dr. Fadi Fahim. He's a lecturer in Orthodontic department in Cairo University. I'd like to thank you so much for inviting me for such invitation or for such conference. Thank you.
Any questions for Dr. Oman, please? Yeah, wait for the